Hello everyone. We'll be discussing about PDA today, but before going on to PDA proper, we'll see why I've put this particular picture over here. We're all well aware that congenital rubella syndrome, it is one of the causes why a child can develop a patent ductus, especially when we are talking about a small for gestational age child. Now, these days we immunize all the kids with the MR vaccine. All the adolescents are also given MR vaccine, but this vaccine actually it came into existence in the year 1969. Before this, in the year 1964, there was a huge epidemic of rubella in the US, and they reported around 12.5 million active cases of rubella and 20,000 cases of congenital rubella syndrome during that epidemic. In that particular year, there was no other way to immunize kids against this particular virus. So what people used to do was, if any of their kids would develop rubella, they would call all the neighboring children and expose them to this particular virus, and it used to be called as a German measles party or a rubella party. But this practice was basically eventually held dangerous. We'll see why it was held dangerous and it had to be called off. Now, this German measles parties, it wouldn't pose much of a health hazard to the children per se, because we know that postnatal rubella, especially if it occurs in childhood, it is a very mild illness. It just comes and goes, and the child gets exposed to it basically and gets immunized. So it's not much of a health hazard to children per se. But what happens is, with increasing active cases of rubella, active rubella cases, this would increase the chances of expectant immunologically naive mothers to get exposed to this particular virus, and their fetuses would in turn be at a higher risk of developing congenital rubella syndrome. And therefore this practice had to be called off, because the immunologically naive mothers who were expectant had an increasing chance of getting exposed to this virus, and their in turn in their fetuses to develop congenital rubella syndrome. So this practice had to be called off, and in the year 1969 MR vaccine was introduced, following which there was a drastic decline in the incidence of both rubella and congenital rubella syndrome. So that's about the newspaper clipping basically. Now let's go on to PDA proper. We'll discuss PDA under the following headings. First, we'll see a few more interesting historical snippets about how our knowledge about ductus evolved and where do we stand at present. And following which, we'll see a few embryological aspects of development of PDA. All the remaining topics will be dealt in the next video. Our knowledge about the ductus, it dates back to 200 AD, when Galen first proposed the idea or possibility of a connection between the two great arteries, and it evolves over the years. We'll learn about the contribution of each of these physicians in the coming slide. The very first concept was introduced by Claudius Galen. He was a Greek physician, surgeon, and a philosopher. Although he himself had a very erroneous concept of circulation as whole, he was able to decipher that since lungs did not move or respire or breathe in utero, the entire blood which was supposed to be directed to the lungs should somehow be redirected to the systemic circulation, and therefore there has to be a ductus which has to be patent in utero and has to be a connection between pulmonary and systemic circulation. He was also the very first person to believe in a four-chambered two-circuit heart. But he erroneously believed that venous blood was formed in liver by absorbing nutrients from gut, and this venous blood flowed to the systemic side via pores which were present between right and left heart. So that was an erroneous concept which he had, but also he was the first person to believe that there has to be a ductus which has to be present between systemic and pulmonary circulation. The core concepts of circulation were laid years later by William Harvey in 1600s. In his book Anatomica de Motu Cordis, or concerning the motion of blood and heart, he put forth a very simple yet very important mathematical proportion that if Galen's theory of venous blood being formed by liver were to be true, or were to be held true, liver will have to produce 498 pounds of blood every single day. This is more than the weight of entire body, and hence is not physically possible to happen. He went on to prove further how blood circulated in circles and wasn't being produced in liver. He experimented in lower animals and later in humans, and found that whenever the veins are being tied, heart becomes empty, and whenever arteries are being tied, the heart swells up. Further, in his description of how the blood circulates, he reiterated the importance of ductus. So basically, we have Galen and Harvey who told that there exists a thing called ductus. But the concept or the idea that ligating a ductus can improve health It came years later, and that was put forth by Dr. John C. Munro. In the year 1907, while delivering a lecture to Philadelphia Academy of Surgery, Dr. John Cummings Monroe, he recalled that some 19 years ago he had seen a patient, an infant basically, who presented in severe cardiac failure and eventually succumbed to her heart failure. Upon doing an autopsy, Dr. Monroe found a ductus which he was able to ligate, and he saw that the ductus was very superficial in location, and because of its location, he reasoned that he could also ligate it in a live patient. See, the concept of cardiac surgery was completely unheard of back in 1907, because if you're doing a cardiac surgery, the heart needs to be stopped, and that concept hadn't come up yet. The very first cardiac surgery which was performed was done in the year 1952 by Lillehi, and it was done under hypothermic with the cross circulation. But ductus, being superficial in location, could also be ligated in a beating heart, and you need not stop a heart for ligating a ductus. That is what Dr. John Cummings Monroe wanted to tell. He instead received a lot of ridicule from his fellow pediatricians, and therefore he could never bring his idea into action. The very first attempt at ligating a ductus in a live patient was made in the year 1937 by Dr. John Strider. He received a referral of a 22-year-old female patient who had a patent ductus and also had developed subacute endarteritis in that ductus. Because of that infection which she had developed, the pulmonary end of ductus had developed a lot of adhesions, and therefore Dr. Strider wasn't able to completely ligate it. He was only able to partially ligate the ductus. Even though he was only able to partially ligate it, the patient post-operatively in the immediate post-op period showed drastic improvement. But eventually on post-op day 4, she passed away. So that was sort of a failed attempt. Immediately a year after this, in the year 1938, Dr. Gross performed the very first successful surgical ligation of ductus in a live patient. Dr. Gross was basically a young surgical resident who was working under Dr. William E. Ladd, who upfront refused any idea of performing any such surgery under his supervision. It is said that Dr. Ladd, when he went for his summer vacation, Dr. Gross decided to operate on 7-year-old Lorraine Sweeney. The operation, in fact, went uneventful, and the patient, she was able to sit up on the post-op day 1 itself, and she was in very good health, and eventually she got discharged really early in a very good health. However, Dr. Ladd, when he returned from his vacation, he dismissed Dr. Gross. Anyway, this is Dr. Gross and Lorraine Sweeney on the 25th anniversary of ductal closure, and this is Lorraine Sweeney in the year 2018. She's a 88-year-old grandmother at this particular time. The next major report in the history of ductal closure was percutaneous ductal closure, and this percutaneous closure was done by a radiologist, not a pediatric cardiologist. So Dr. Werner Postman, he was a German radiologist who for the very first time did a successful percutaneous transcatheter closure of ductus. That's all about the historical aspects. Now coming to the embryology of ductus. Ductus basically arises from the 6th aortic arch. The distal portion of 6th aortic arch, it gives rise to ductus, whereas the proximal portion basically forms pulmonary arteries. And this happens under the influence of neural crest cells, which in turn are regulated by genes like TFAP2 beta or transcription factor AP2 beta, which we'll see in the coming video that it is implicated in diseases like familial PDA and also Char syndrome. We'll see that in the next video. Thank you.